My topic is in a tricompartmental osteoarthritis, whether doing CR, PS, or medial pivot, does it matter? Now, as far as the CR and PS goes, the debate has been going on for years and years together. Every conference has this debate. Now, it is a sort of an unresolved controversy. And, these are basically two philosophies, right, which have, there is no superiority of one over other. The modern TKA evolved with introduction of total condylar prosthesis in 1974 by Insal and Dr. Ranawat at New York. It sacrifices the PCL, but there was no mechanism for rollback. So range of motion was restricted to 90 to 95 degrees. In PS or cruciate sacrificing TKA, in normal knee with flexion, femur slides and tibiofemoral contact point moves posteriorly. This tibiofemoral rollback is a function of the PCL. In the PS knee, PCL is sacrificed and its function is ensured by cam and post mechanism. It gives consistent rollback and the range of movement also improved. In CRTK, the PCL is preserved and balanced to produce normal femoral rollback. Now, differences in PS and CRTK, of course, there are differences in indication, in patient selection, and in surgical technique. Now, PS can be used in all the cases. CR is generally not recommended if the PCL is dysfunctional, especially in deformities more than 20 degrees in any plane. But there are some purists like Dr. Ashok Rajgopal who can do a CR knee even in a fused knee also, right? And he says that he has never used PS. Now, merits of PCL preservation or a CR knee: it maintains the normal knee kinematics, less bone resection as the post is not required, joint line is better maintained, proprioception is better, they have normal stair climbing ability, and lesser shear stresses on the bone cement interface. What are the disadvantages of PCL preservation? If the PCL is tight, it's going to limit your flexion. It may cause excessive rollback, and it will cause polywear of the posterior edge, leading to aseptic loosening. Loose PCL, of course, there is no rollback, and it can cause paradoxical anterior translation of the femur. Merits of PCL sacrifice and substitution: it gives a better exposure of the posterior part of the joint. It's easier to balance. There is a definite rollback and more conforming poly, so reduced contact stresses. Disadvantages of a PCL sacrifice is a more bone resection, and there is something called the patellar clunk syndrome. You are aware of it. There is post-wear and post-fracture can happen, and a unique complication to PS knee is cam over post jump if the balancing is very poor or improper. Now, decision to retain or sacrifice PCL depends on individual surgeon preference based on his experience, knowledge of kinematics, and of course functional outcomes in individual practice. CR or PS, now there are innumerable papers and meta-analysis, and they have demonstrated there is no difference in Knee Society pain score, functional score, complications, or even gait pattern. Cochrane review, 18, and there is no difference in the clinical outcomes of CR or PS knee. Little word about deep dish or ultracondylar inserts. In younger patients and those with small osteoporotic bones, there is a tendency to preserve the bone, and in those cases, CS or ultracongruent inserts offer some restraint as cam and post while preserving the bone. A little bit about medial pivot or a medial congruent TKA. In normal knee kinematics, the posterior aspect of the medial femoral condyle has a single radius of curvature. It acts like a ball in socket between 20 and 120 degrees of flexion. This allows the lateral condyle to pivot around it. Now, design of medial pivot knee, it was based on the work of Freeman and Binskarova, who is a lady from Hungary. Stability and design of implant mimics the natural knee kinematics. It has an asymmetric tibial insert with highly congruent medial compartment and less conforming lateral compartment. Raised anterior lip of poly achieves anterior posterior stability and control of condylar lift-off. Medial ball and socket design allows lateral femoral rollback just as the normal knee. And while on the medial side, it moves about 3 to 4 millimeters. On the lateral side, you have excursion almost up to a centimeter. 7 to 11 millimeter it moves posteriorly on the lateral compartment. Merits of medial congruent TKA, it produces normal knee kinematics. It gives more AP stability along with large contact area with low contact stresses and higher conformity. Is definitely not inferior to traditional TKA and may be potentially superior. This is a study by Batra et al. They studied about 53 patients in whom they did bilateral TKA. On one side, they had used PS TKA, Genesis 2 by Smith and Nephew, and one side they had done medial pivot TKA using Microport advanced implant. And they found out that the knee society scores were higher in medial pivot knees, and in vivo kinematics of MP was better than PS knee. Now, registry data, it's a little busy slide. You have National Joint Registry, then I think from Australia, New Zealand. So they have studied about 5 registries, 25 studies, 3,684 cases. Survivorship free of loosening was 99% at 7 years for medial pivot knee, 97.3% at 15 years for advanced medial pivot TKA, and it was 98.8% at 17 years for Microport advanced. Now, Australian and Norwegian data, they had little increased risk of revision for osteolysis and loosening in medial pivot knees. Now, this means that not all MP designs work equally well. The results are definitely based on implant design. Currently, there is a very small cohort of medial pivot designs is available, and long-term follow-up and larger cohort is definitely needed for definitive conclusions. Here I end my lecture. Thank you so much.